Okay. Okay. Good evening, everyone. I'm going to get the meeting started just because I do know that our special guest does have another commitment, so I want to make sure that we have time for that. So I'd like to call the meeting to order. At this time, I want to offer the ability for anybody to make public comment on our current agenda items. Seeing none, we will move on. At this time, we need to approve our minutes from the previous two meetings, the November 18th and November 4th. Do I have a motion to approve our minutes?
Motion. Second.
Second. Okay. And all in favor?
Aye.
Motion approved for the minutes. At this time, we, as new business, we are going to approve the schedule for our 2022 Board of Health public meetings, which will begin in January at the first Thursday of the month and continue every other month throughout the year. Do I have a motion to approve that schedule?
Motion approved.
Okay. Second. All right, all in favor?
Aye.
Any opposed? All right, our motion carries. And then at this time, under new business, we are happy to have an update from CRozier Health System. We will begin with Peter Adamo, who is the CEO of CRozier, who is joining us virtually.
All right, can you guys hear me and see me?
So I kind of hear Peter. Sean, do we have him? Hi, Peter, can you hear us?
I can hear you guys just fine. Can you hear me?
Yes.
All right, good. So with the AV check behind us, I will introduce myself. I'm Peter Adamo. I'm the Chief Executive Officer at CRozier Health. I've been here not quite 2 years. I got here just a few weeks before our first COVID case arrived. And Rosemary, I have a little more time than I thought I might. So I don't need to be anywhere till about 6:50. We have a CRNA anesthesiologist graduation tonight. And our feature speaker has COVID, so they've asked me to be the keynote speaker. So I quickly put together remarks today, and I know that somebody from CRozier needed to be present. So that's the reason for me not being there. I've got to head across the street in just a little while. You'll hear a little later from Joe Rafferty, who's our legislative affairs representative, and he's prepared a PowerPoint. But what I think you guys want to hear from me, I suspect, is an update of CRozier, but that's really a question that begs for what was in the newspaper a few weeks ago, which was the notion that our health system was being sold. And what I should do is step back for a second, tell you what the parent company, Prospect Medical Holdings, is doing. I have to tell you, I'm a little disappointed in the way our own organization has messaged this, because like every health system in the United States, we're all looking to secure the next phase of financing for our needs. As you would imagine, our business is an awfully expensive business, and anything we do in healthcare always seems to be 10 times more expensive than doing something in a non-healthcare setting. So our equipment, our buildings, our staff are all expensive investments. It is difficult not to spend less than $1 million no matter what you're doing. CTs, MRIs, path labs all end up costing in the neighborhood of $2 to $3, if not $4 million. So what the parent company is doing is trying to secure financing in the long run. There are a couple of ways to do this. Unlike in the not-for-profit setting where you can float a bond and borrow money and pay it back, we don't have that latitude here, nor do we have a foundation that could raise money and send it our way. So we're doing it the old-fashioned way. We're trying to find investors. But we also know that if we're not successful finding an investor on a national level, we're also looking at partners who might be interested in working with us. And what that does, particularly if they're not far away from us, it may be able to keep us from having to duplicate services. There's nothing, no greater travesty than for two health systems to believe they both have to have the exact program just miles away from each other, and both are being underutilized. So we are talking to local health systems about the possibility of partnering with us. And that could, although it's more a remote possibility at this stage, but it could lead to a potential sale, if not merger between two health systems. We're not the only entity at Prospect that might be involved with such discussions, but I think the mistake we made is that had we told our story before things got out of control with rumors, I think everyone have agreed that's not much news to the fact that you're looking for ways to make sure that you have the hundreds of millions of dollars that you might need. And I can tell you this, that the CRozier Health System does not spin off hundreds of millions of dollars of surplus earnings that can be invested in all the things that we need on a go-forward basis. And you'll know this too, is that as a hospital, if you don't have modern equipment, you may as well not be a hospital. So you've got to find ways to secure the money it takes to do these things. And when Prospect arrived in 2016, there was a lot of deferred investment. And that's what you would imagine would happen with an organization that may have been struggling for the decade prior. So I want to just get that out of the way. Now, one of my doctors came to me the other day and said, Peter, we're not as worried about the situation with, a sale or a merger. We're really worried about CRozier being the next Hahnemann. And I paused and I said, I never would have imagined that. How about that? Me being the chief executive here and never having imagined that being a fear. And I had to sit down one night and say, what is the difference between our situation and the Hahnemann situation? And I think one of the things we've learned from the Hahnemann experiences is that they had a pretty easy escape route in front of them. When that deal was consummated, one of the options that was available to that investor was the option to liquidate and turn that real estate into valuable return. We don't have that option. I have an asset purchase agreement that prohibits it. I have a 20-year lease on most of our buildings that would still require me to pay the lease payments. So I really don't have the option of closing. So please, if that's what a lot of folks are thinking is going to happen here, and that we would orphan 150 residents and a bunch of fellows the way Hahnemann did not long ago, I don't think we even have that prerogative if we decided to do that. But we're just too big to fail. I think in the city, you'll notice that while Jefferson and Temple and Penn are busy, they were quick to absorb those patients who were formerly seeking care at Hahnemann. We were overbedded in Center City, Philadelphia. We are not overbedded in this county. Now, granted, some of my buildings are not as full as they could or should be, but we have plans to backfill that space by integrating both vertically and horizontally and being able to do some things that don't take any services away from any of our markets, but instead enhance the levels of services that we provide currently. So that's where we're heading. And I wanted to just get that out of the way before we walked into a presentation about the virtues of this glorious health system that I'm in charge of, because it really is a wonderful health system doing a lot of things in a lot of neighborhoods that a lot of other health systems would prefer to avoid. And I'm darn proud of that. And I think if Joe would go through his presentation in a bit, you'll see some of the things we're doing, and this is just the tip of an iceberg. So I thought I would open with those comments, maybe put to bay some of the concerns about, what's happening at CRozier. And I can tell you this is we're going to be around. We may change names. That's a 10% chance that could happen, but that's not going to happen overnight. And if it does happen, no matter what direction we go, we're going to be in a better position financially because we're going to need this money to do the things that keep us current and advanced. So what I should do is maybe open the floor to questions. Is that the right thing to do, Rosemary?
Yes, we can do that. Or did you want Joe to do his presentation?
I'm good either way. I think it would be wise for me to maybe answer questions now. If this is the big concern, I would love to be able to put those concerns at bay and at least give you the rest of the story.
Sure. I'm going to open it up to the rest of the board to see if anyone has questions. PJ?
Peter, thanks for being here tonight, or being available tonight with your busy schedule and giving us your insights. I'm PJ Brennan, a member of the Board of Health. It's unusual for hospitals just to suddenly close outright. And what happens more typically is that they go into a spiral of reduced services in which patients and clinicians begin to flee, and then there's eventually no return from that. Are there considerations of reducing any of the services that you currently offer? So let me start with that.
Yeah, we're always examining the viability of services. At one point in time, I think we were doing endoscopy work in 8 different locations, and each of them was not really as busy as you'd like. So it was hard finding enough doctors to be in 8 locations, and we distilled that down to 4, and it seems to be working. I think we're going to have to add one back. Taylor, I think, is looking for some additional services, so we're going to have to get creative. But these days, it's not just doctors that are limiting your ability to get things done. It's nurses, and now it's gone even deeper than that. So most hospitals are struggling just as we are. We're not unique, in that there aren't enough staff members to be able to staff things. I would have loved to have reopened Springfield, but we're having a hard time staffing the 3 hospitals that are open. So we continue to run the outpatient services at Springfield. The ED is still open, just as busy as it was prior to COVID. So we're always looking. I think that if we are duplicating things, what we may do is, if we decide to merge some things, is perhaps expand what we're doing now on an outpatient basis, because as inpatient services become less necessary, meaning the anesthesia processes are simpler, the recovery times are better. We can do a lot of things robotically now, which don't require, I should say, the amount of recovery time, so that you can get folks home at 7 o'clock that same day, if not the next morning. You'll probably see us shifting more towards outpatient activity. And the beauty of outpatient activity, it tends to be 7 to 3, Monday through Friday. It's a little easier to staff, and it's less inconvenient for the people who work in those environments. So don't be surprised to see us doing that. And you'll see even Mainline doing the same sort of thing. Their investments in brick and mortar tend to be outpatient right now.
So if you're seeking an investment of $100 million, that's, by any standard, that's a substantial investment. Mm-hmm. What would the role of the investors be, whether they're venture capitalists or individual investors? Do you contemplate offering board seats, some measure of control in the organization? How will the investors be engaged?
If I know the parent company and I know the owners, they're pretty good guys. My guess is that they'll ask for folks who will invest at the national level and be silent, essentially. If that's the route that is chosen, we won't do anything locally if that's the case. But if we are part of another health system, let's just go down that scenario, I don't know what to say. It would all depend upon how things get negotiated. But at a national level, I would think that, if somebody came to us and says, we have $1 billion, we want to invest, we like what you're doing, we need a decent return on it, and here's some grace period for it all. That's essentially how it would work, just like a bank. You still got to pay somebody back if they've lent you money.
Thanks.
I have a question about decreasing services. Is there a contemplation about closing the maternity ward for CRozier?
Well, we wouldn't close anything. If anything, we would try to consolidate where those consolidations might be possible. We deliver babies in 2 locations now. We have 2 separate NICUs in 2 separate locations, which means you now have to have 2 physicians on call in 2 locations, 2 anesthesiologists on call, 2 staffs on call, 2 sets of neonatologists, and 2 separate bits of equipment for all of those specialized kids. Right now, we're delivering about 2 babies in both locations. So it's not a very good financial situation for us. And in hospitals, what's important to understand is I can't make up for a loss on the left side of the building with a gain on the right side of the building. It doesn't work anymore like that. Maybe in the past there were opportunities to do that, but it certainly doesn't work at CRozier. If I've got a loss in one area, I don't have something that is making so much surplus earnings that can spill over and work for us. So if we do decide to do something in the upcoming year in maternal services, we would not be abandoning a community altogether. What we may be doing is taking a look at ways to not do things in two locations that are done on an occasional basis, and maybe augment our presence in the field so that prenatal care on an outpatient basis is even more prevalent and more accessible than it has been or is today. One of the things I learned is that many of our campuses are old, they're difficult to navigate, and while they're along certain bus stops, we don't really, it's not all that convenient for mundane services to be performed on our hospital campuses. So we continue to look at ways to bring more of the hospital or formerly hospital-based care out into the community. And I think that's what you'll end up seeing, not just in women's services, but with much of what we do, including psychiatry and urology and OBGYN. The more we can do closer to home, the more likely it is it'll be accessed and that problems will be intercepted sooner instead of later. And if we do go at risk, the key is to try to solve the problem while in its infancy, and it's less expensive than allowing it to exacerbate and become a very expensive problem to manage with sometimes very poor outcomes. I hope that answers your question.
Thank you.
So, Peter, you mentioned the problems with employees and sustainability of that. Can you talk about, the exodus of a lot of the employees and what you're doing to try to mitigate that?
Oh, yeah. You know what I can do is I can send you a list of roughly 30 things we've done. We do all the traditional things that we had been doing before COVID, right? And just about every hospital is in the same position. We talk to the folks at Temple, we talk to the folks at Mainline. Everybody's struggling for staff now. Yes, there are some people who are leaving, and many of them are not even going to other health systems. Many of them are going to places like Amazon. Many are just working from home. And it's a giant resignation of all forms. Our problem is that we really can't do a lot of our work remotely. There are people who have come to me who have historically performed work that was face-to-face and have told me that unless I offer them remote capabilities, they're going to resign. And we're scrambling to try to figure out how to do things that formerly were done on-site, off-site. And we've been pretty successful with a lot of it. Back office things are easy to do remotely. Matter of fact, I almost enjoy the occasional morning where I have my coffee in my office at home, make a few phone calls, and then stroll in at about 10, 11 o'clock that day. So I can understand why the appeal for remote work is as big as it is. So we're moving pretty quickly to do that. But some of the more innovative things we're doing is, we have been offering referral bonuses, $10,000 to our own people. And if they want to, they can refer 10 people in the course of a year. That's a nice income on referral bonuses to bring us staff. And the other thing that we've recently introduced is a $50,000 total over the course of 5 years loan forgiveness program for nurses, physical therapists, and we plan to expand that to other job titles throughout the organization. Because believe it or not, we can hardly find phlebotomists these days, and everybody's fighting over them. And the hourly rates are climbing, but we're trying to find ways to replace the RNs. And some of the things we're doing is we're reached out to all of the LPN schools. This is the most encouraging thing I've heard in a long time, is that at least in the Philadelphia market, the enrollment in LPN programs has tripled since the advent of the COVID virus and its pandemic. That tells me that there are people rushing into this field while others are exiting who really want to make a difference. And the beauty of an LPN program is it's only 1 year, where an RN program is a minimum of 4. So I really love the idea of finding these LPNs, having them work alongside of our RNs. We've established an EMT program where we're training our own EMTs. We'll be graduating 2 classes a year, and they too will be able to help us out in the EDs and other sorts of places. We're also creating some new job descriptions that are brand new. We are putting in place a RN retentionist. I've never heard of such a thing before. One of our California hospitals wrote a job description. We took it, we modified it, and we're advertising for it. So if anybody wants to be a RN retentionist, come see us. We got a job for you. We're also doing logistics techs work because we've learned a couple of things about a typical nurse's day. A third of it easily is spent at a keyboard typing. And I think there's some technologies that are ready to explode that will allow the nurse to spend more and more time in the room with the patient where her joy should be coming from. I don't know anybody who finds a lot of joy in typing. Maybe there's a few of us out there that still enjoy typing, but I don't think most people that got into healthcare want to type. I think they want to be alongside their patients. And I think that their longevity would increase and the amount of joy they leave with each day would increase. So we're heavily exploring those technologies. So in the years to come, we can free up and maybe essentially give back 30% of the day to the caregiving staff so that you have essentially brought back 30% more capacity with the folks that are with you already. So those are the things I'm able to remember here on the call, but the list is awfully long. And if you like, Rosemary, I could email you this list because we put it together about 3 weeks ago. And I said, what are we doing? Because there's so much that we are doing and everybody's doing the same kinds of things. But I think we may be a little more rich in some of the things we're doing right now because we realize that, Chester Upland and Upper Darby may not be places where people are running to right now. Many of them are looking for the prestige of these bigger systems. So we're having to spend a little more money than they might at the bigger, more well-known entities. So I'll be happy to send that to you.
Yeah, that would be great. I think one of our concerns is really ensuring that, the services are continue to be provided to the community, especially in the, Chester Upland and Upper Darby area. And where there wouldn't be a really close health system nearby to ensure that they have the services that are currently provided there.
Yeah, those are our concerns too. We realize our mission and that we really need to be in as many neighborhoods, particularly the neighborhoods where other folks don't have a presence yet today and may not be rushing into those communities.
Right. Anybody else have any questions? Well, it'd be great if you could send me any of the information that you mentioned. I know you have my email address. And if you, I'm sure as this progresses, keep us informed. So, and if we can provide any assistance from the county perspective, please let us know.
I appreciate that. Thank you. And good luck, Joe. Thank you.
So, Joe, did you have a presentation too?
How the presentation works.
Sean does his magic.
Yeah. And I'm not going to go through slide by slide. I know everyone knows CRozier, but maybe there's some things maybe you didn't. I think it's just important to understand the scope of services that are provided. I'll start with this. Let me give you my background very quickly, if that's helpful with everybody. My name's Joseph Rafferty. I've worked with CRozier for, over 5 years now. I've been at Prospect for going on 7 years. Prior to this, I was in Texas and in California. I grew up in California healthcare. Worked with Tenet Healthcare out there, which is a big for-profit, publicly traded company. Then I worked at Stanford Health System in Palo Alto. My family and I moved to Houston because we have a lot of family there. Originally from Cleveland, Ohio, but we didn't want to move back to Cleveland, moved to Houston. And I worked in Moore Herman, which is a very large, probably one of the best nonprofits out there, et cetera. And so in a way to kind of get back up towards family, moved up here. Prospect offered me an opportunity. But I ran their Texas region for about 1.5 years before coming up and actually being the president of Taylor Hospital in Ridley Park. I was president of Taylor Hospital for 3 years, and I was also the president of our EMS company. And I don't know if everyone knows that, but we do have a very large presence in EMS. So I'll just start from there. And I sent this to Dr. Taylor and Rosemary, they can share with you if you, on your free time want to look at it. So just some history. I'm not going to go through the history of the timeline. I just think it's interesting. There's kind of how it all started. But let's just get to present day. That's probably the most important piece. We're currently about 4,000 employees. We have about 1,100 physicians on our medical staff. We have 160 residents and fellows. When you look at the physician base, about 300 of those doctors, 300, actually a little bit more than 300, are employed physicians in our medical group, okay? So as Peter mentioned before, we have 4 hospitals, right? We have CRozier Chester in Upland. We've got Springfield Hospital, currently does not provide inpatient services due to COVID. We shut that down, et cetera, as Peter mentioned. We have Delaware County Memorial Hospital, and then we have Taylor Hospital. So just don't need to go through all the details of that, but I think you all know where those are. And stop me, please, if I'm overlooking something that's important to you. We do the multi-specialty centers. These are really the outpatient pieces, right? We've got Broomall, which has been highly successful. It's been a nice model for us from an outpatient perspective. We have Sean, I don't know, you might need to help me with this. And then we have Britton Lake, which has also been a very successful outpatient. We also do a lot of surgery up there as well. So you have a surgery center plus a lot of outpatient, like imaging, et cetera, that's there. We also have an imaging department, radiology, and media as well, downtown media. We have a surgery center, a joint venture surgery center with a bunch of docs in Haverford as well. You're all aware, I'm sure, of our behavioral health presence. It's really, outside of being one of the best in burn in the country, we have 50 psychiatrists on staff that are employed, which is really impressive with the shortage of especially that specialty. But we moved the community campus, that building, and we moved it across the street from CRozier's campus in Upland, and opened that inpatient site there. And then we also partner with the county, and we have rejuvenations at Fair Acres as well. There are other plans in the future. We're building out a crisis center at Delaware County Memorial Hospital. We're also trying to build out inpatient beds there as well, from a behavioral health perspective. So we kind of want to bookend, it's almost like a bookend of the counties, right, in our most needed areas. And the two things that we do, behavioral health is really broken into two things, which is one's mental health and the other substance abuse. We do both at the CRozier campus, and we're looking to do both up in Delaware County. This, I think, is really important for everyone to understand. A lot of times I would say, as hospital administrators, we overlook the front, basically our first responders. We have a hospital-based EMS company. It's been around since the early 80s. In Upper Darby alone, let me give you an example. I was president of it for 3 years, so I know it very, very well. In Upper Darby alone, we've done over 400,000 calls since our inception. And we don't have an agreement on Upper Darby, we just have provided that service for decades, literally. We currently have, we have 2 divisions. One's in Upper Darby and one's in CRozier Chester. That's where we have our bases. We do about 35,000, a little over 35,000 calls a year, 911 calls a year, okay, that come from the county emergency center. We have a great relationship with the county. Tim Boyce and folks, we work. There isn't a week that goes by that we're not on the phone with Tim or different folks. It's a really great relationship and partnership. And we have a lot of great partnerships with various townships as well. The one area that we do not cover fully is Springfield Township, because Springfield has their own EMS company that's separate of the township. But what we do is we do staff that at, it is is our paramedic that's on there, and we still back it up with a response vehicle. So we don't provide the ambulance itself, but they are CRozier staff that actually are in the vehicle. Okay, so we are the largest provider of EMS in the county. I think we provide, I think the last percentage was like over 52% of all 911 calls in the county. You can see kind of the FT base that we have. If we're going to be completely straightforward with this, we lose about $7 million a year on EMS because EMS used to be a big profit center for fire companies. Okay, and any of you that are familiar with Ridley 7, I don't know if anyone is familiar with Ridley 7. So Ridley 7 was down in Ridley. It was a joint venture. It was a partnership with, I believe it was 5 different fire companies. That was the revenue center for the fire companies, so they could, recapitalize their vehicles, et cetera. Well, in the past decade, reimbursements changed. Everything's changed. The model has changed significantly financially. So they basically went out of business, and we took over that because they were being taken off the run cards. So we are automatically kind of taking the calls anyway. So we kind of helped the process of them moving along. It stressed our EMS company, but we worked hand in hand with the Ridley managers, and it's worked out fairly well. But that just tells you when something that was a profit center is no longer a profit center. You can see how it goes. They're no longer in that business, and that said, the fire companies are struggling because they don't have a revenue source, right? So TMI probably for everybody, but I've been in this too long. One of the things I'll tell you that we're extremely proud of in Upper Darby, especially in Upper Darby, we do so much. I can talk about Chester all day long, but Upper Darby, one of the things that we do, it's the last bullet point, is the homeless outreach. We do that completely. These are the things that the services that are provided, basically free of charge, right? We go out. We have a doctor, and we usually have a paramedic with the physician that actually they go into the station, they find the homeless people that are there that are in need of some sort of medical care, and they provide that care, right? So they do that every Wednesday night. It's been it's something we're very, very proud of. The team is actually very excited to do it. The docs are very excited to do it. So just wanted to share that. We do events all over the place. We back up the fire companies whenever there's a mass casualty event. I'm sure you guys get the emails about mass casualty events. Well, our EMS team is usually there. They're backing up the fire companies, the police, et cetera, when that happens. So we're involved in pretty much everything that goes on from an emergency perspective, and we're very proud of that. Employed physician group. So this is interesting. We have about 300 plus physicians that are employed by the health system. They see over 335,000 visits a year and counting this year. That's just from this year alone. And you can kind of see some of the specialties that we provide. We were able to, with a partner group, to actually become a comprehensive stroke center down at CRozier Chester in really a very short period of time. And so that's actually helped the community out a lot. Now those ambulances aren't being taken out of service to go out of the county to take them to other facilities, right? We are servicing those patients and getting those ambulances back on the street as quickly as possible so we can service the next emergency that comes up. And as you can tell, there could be 4 or 5 emergencies happening at the same time. So we need those ambulances back as quickly as possible, back on the street. That is pretty much the overview of CRozier Health. There's a lot more. I will add one other thing, and it's something that Peter's done as a CEO, that he's it's part of every employee's evaluation. it is mandatory for all of our employees. So we have 4,000 plus employees, but really we have about 100 plus directors, not. It is mandatory that everyone is involved in some sort of community. It could be coaching a team. It could be part of some other nonprofit that's whatever volunteer, right, in the community. It is mandatory and it's on your evaluation every year. Don't tell Peter, but he gave me a 4. You know, and I'm treating you all the time. I'm sure you got a 5. Anyway, but those are the types of things that I think what Peter's brought in has been very positive. Is the thought of being in the community and ensuring that people are getting back in the community, because we've been disconnected for a while. We all know that. So if you have any questions for me, please let me know. I hope that was helpful. Maybe there was something there you didn't know, hopefully. And I appreciate your time. So if you have any questions, I'm happy to.
Thank you. Well, I just know from our COVID response, we definitely integrated with your EMTs a lot in many of our sites and trying to help us provide those services, and then also with the homeless outreach that you helped us do with COVID vaccinations.
I have to tell you all, our chief, Bruce Egan, which Rosemary, you know Bruce, Chief Egan. Phenomenal, just one of those people that is, you can call him any time of day or night, and he's just there. So we've been very fortunate to have him take over EMS a couple years ago and kind of really start shaping it. So we're fortunate for that. And he was one of the first people we had at CRozier who got COVID, which was the craziest thing. Where it's like, I remember he actually called me. I'm very close with him. He called me and he's like, I'm not feeling well. I'm like, okay, well, that's great. A couple days went by. It's like, I'm having trouble breathing. I said, you're supposed to go to the emergency department. He finally went to the emergency department. Well, fortunately, they put him on oxygen and he was fine. But yeah, he's been a blessing to the organization, that's for sure.
Can you say a little bit about how COVID has impacted the organization? You know, Peter was talking about the Great Resignation. I mean, how much turnover have you had? What was the impact? I'm sure, you know, like all the rest, you were locked down and couldn't do non-essential services, especially in the spring last year. I mean, how did that impact your finances? And
I can't give you exact numbers in terms of like the percentages, et cetera, because I don't have those, so I wouldn't want to speak to it off the top of my head. But what I can tell you is that our rates of pay, just like everywhere else, have skyrocketed. So the inflation and the rates of pay. We have some nurses that we're paying $250 an hour.
the employed nurses or travelers?
No.
Employed nurses. Yeah. Mm-hmm.
Absolutely. Because of the way that the system's set up, et cetera. But what I would say is we've lost nurses to go to travel, right? Every system's seen that. I mean, they're taking advantage of that situation.
Mm-hmm.
That's supply and demand economics. It's fine. Yeah, we've seen, you know, other staff members that just what Peter said. We've seen people just leave, and what we've had to do is we've had to actually consolidate units. So like at CRozier Chester, we have 2 units, 3 west. I think it's 1 west and 3 west. Right? We're consolidating down to 1 because we just don't have the staff to staff both.
Mm-hmm.
So we are having to constrict because of that. From a premium pay, what I can tell you is, as of, I believe it was, I think it was September of this year, our premium pay, when you look at it, when you take out of the what you normally pay people, right, the baseline, and you look at our premium pay year over year, we were running this is only in September, we were running $5 million over prior year. So what we'd be paying, basically, we were still running after we paid overtime. We normalize all that, we were still running $5 million over, and the clock was still ticking, like in terms of the dollars. I mean, I would assume we're going to be over $10 million easily, in additional just that from the baseline of previous year.
You mentioned having to consolidate units. How much have you had to reduce your bed complement in order to accomplish that?
I don't have that exact number, so I apologize. I mean, I can get that information and get it back.
Okay.
I don't have that exactly.
Hi, I have a question. Thanks for your presentation. I'm just thinking in terms of the exodus of staff, have you all done any sort of internal review or analysis on the quality of care people are getting because of this exodus and how that's impacting the care that people get, that patients get?
You know, like in every hospital, right, there's a, quality of care is measured every day, right? Outcomes are measured every day. So we have that built in like every other health system in terms of and how we report out. We report out every month. You know, if there is a bad outcome, we report it through the right channels, right, through the state. I haven't seen, I can't speak to that specifically because I haven't seen anything that says due to staffing shortages that bad outcomes have actually increased. I haven't seen that. What I will tell you is, what I can tell you, the stat I do know is on the EMS side, is that due to patients not coming to the hospitals during COVID, our dead on arrival percentage when we showed up. I'll tell you that. So, has care diminished? I can't say that it has. I mean, our star ratings improved. I mean, all these things are improving based upon what we report to third parties. I don't have any specific incidents or anything like that. I'm sure I don't have anything specifically I can say.
Okay, thank you.
Or data that shows the correlation between them.
Well, thank you so much for the presentation, for the
Thank you.
time to come here. You know, you've been so helpful during COVID, and so I appreciate all your support, and we hope to continue the relationship.
Yeah, well, thank you all for everything. We appreciate it.
Thank you.
So at this time, we do the final request for public comment. Seeing none, I need a motion to adjourn.
So moved.
Second?
All right, all in favor? Aye.
Aye.
All right, so we are adjourned till January 6th for 2022. All right, thank you.